Yes, good morning everyone. I hope everything is okay both on Facebook and on YouTube. And greetings to every one of you. Welcome to another episode on the Oral Pathology 360 channel, the Fundamental series. Whereas the name suggests we go back to basics. I'm Dr. Mandana Donahue, and if it's your first time here, I hope you will enjoy the content. The webinars here are all about delving deep into the subject, and that is why we have a speaker and an expert. So don't hold back, share your thoughts and questions and in the chat box, and we shall discuss them as we go on. Today's session is on the very basics, artifacts. Literally the bane of every pathologist's life, especially if you don't know how to recognize them and prevent them. So the lecture is basically to overcome that problem. And it's a privilege to have an expert on the subject, Dr. Tamiz Chelvan, with us for this session. Professor Chelvan is the head Department of Oral Pathology and Microbiology, Faculty of Dental Sciences. Sorry, that's when I get distracted to look around at the other screens. Faculty of Dental Sciences and also member Board of Management, Sri Ramchandra Institute of Higher Education and Research, Chennai. He is also currently National Convener for Dental Council India, competency-based curriculum change for basic medical sciences. He has over 30 publications and numerous guest lectures and has been awarded Achievers Icon Award 2020 in the Outstanding Healthpreneur category for contribution in oral health services to the community. Very active also in professional associations like the IDA, the IAOMP, that is our National Association of Oral and Maxillofacial Pathology, and social and NGO activities of the Rotary International. Welcome, Dr. Chelvan. It's a pleasure to have you here with us. And coming to our expert for today, we have someone in oral pathology that is one of my favorite oral pathologists, Dr. K. Ranganathan, Professor and Head of Department of Oral and Maxillofacial Pathology, Ragas Dental College, Chennai. Professor Ranganathan is globally known oral pathologist with over 170 publications, including contributions to textbooks and over 130 presentations and invited lectures. He is a fellow of the American Academy of Oral and Maxillofacial Pathology and also the Indian Association of Oral and Maxillofacial Pathologists. He is currently the president of the Asian Society of Oral and Maxillofacial Pathology, also the secretary of the International Association of Oral Pathologists and chairperson Fellowship Committee, Indian Association of Oral and Maxillofacial Pathology. He has also been the president and honorary secretary of the Indian Association of Oral and Maxillofacial Pathology and Asian Counselor International Association of Oral Pathology. So that's a career path you can look at if you're planning to get ahead in the international scene. And coming to that, he has also been on the channel, as you can see from the pictures before. And he's also got a little New Year gift all worked out for us, and will not say much. It's not good to open one's gifts earlier than usual, but it is going to be a pathology extravaganza, and now I will let you all keep thinking about what it is till next year. So, welcome to both of you. It is wonderful to have you here.
My pleasure.
And thank you, sir. And just before we start, I will give everybody a little reminder that we have the Dental Oration and Storytelling International Contest is open for just another 15 days. So if you have an interest, we had decided not to open the stories until everyone was submitted, but the temptation got to us. We have gone through a few and they are very interesting indeed, right from, runaway convicts to a photo exhibition that has gone all the way to the space, and actually even a patient and his doctors who celebrated a positive Montu's test for tuberculosis. So there is a lot that's happening and it's very interesting, and I hope you will join. If you have an interest, please check out the details. It is there in the description of this video. Now with this, I think I will just stop sharing and we can go on to the... Yes, I can request you to please start your lecture.
Yes. Thank you, Dr. Mandana, for that brief introduction. And let me thank my mentor, my good friend, Dr. Ranganathan, whom I share all my good thoughts, and I need a shoulder to cry on. So I need Dr. Ranganathan here. So thank you, sir, for your sharing your time here. With this time, let me go with this lecture on Snags in Histopathology Lab. Good morning to one and all. This is Dr. Tamil Chelvan, who wanted to be an oral surgeon in life career, but God willingly, it had to be an oral pathologist and to be in a big institute called Sri Ramachandra Institute of Higher Education. And our institute, this is what we see here. This is an institute of almost 35 years.
Dr. Chelvan, I have to interrupt you. Can you? Okay, you have gone to full screen. Yeah. Thank you.
Yeah. This is our institute. It's about 35 years old institute. We stand number one in the private institute in the whole of India. We have about 450 acres, and we have about 154 courses, medical courses, and we have about 7,500 students and more than 3,000 faculties in our department, in our college. And we also, dental college was started in 1995, and this is our department of oral pathology where we do the basic exercise. And we are proud to say that our department did this Guinness record in 2017, where we brought about 25,000 school children to Rotary and IDA and Colgate, and were taught how to do toothbrushing, and I was a secretary for that particular grand gala event. With this brief introduction, let me take the privilege of thanking Dr. Ranganathan sir for being a part of this, who's going to be an expert in this program. Thank you, sir, and thank you, Mandana, for inviting me to this lecture. Normally, before I start any lecture, it's my habit of thanking my late parents and Almighty for elevating me to this position and where I'm standing in front of you to do this presentation. Whenever we do this histopathology diagnosis, we always see that some artifacts happening up, but we are not really bothered about artifacts because we are concerned only about the basic diagnostic procedure. But at times, these small artifacts will make a mishandling of the tissues and which will give a misdiagnosis to be happened up. So this slide shows us briefly how the tissues travel. So the tissue starts traveling from the clinical side and where we give the report. When these are the pictures, normally we see in our day-to-day practice, but we don't really bother about it. But ladies and gentlemen, there are high chances of these slides can give interrupt in your publication process, especially when you're going for a peer-reviewed journals and for international articles. These photographs will not be much highly appreciated. So though it's going to be a fundamental lecture and it's a very basic thing, there are very few studies been happening both internationally and nationally also. Because when I went for this presentation about 15 days back, I reviewed a lot of articles. There are about not even a single article study has been done in India about these artifacts, what's happening up. And these are the photographs which I've taken from my department where the artifacts are taken up here. So with this brief discussion and what I'm going to talk about it, I'm going to say about the various artifacts happening on the clinical side and from our lab side. I'm going to give remedies also. How can we avoid all these artifacts in a very simple way and teaching our technicians and also the oral surgeons. I'm going to conclude with a good school of thought. So the definition for artifact means Latin word, it's basically an art made. In histology means any non-natural feature or structure that is accidentally introduced into something being observed or studied. Artifacts refers to an artificial structure or tissue alteration on a prepared microscopic slide caused by extraneous factors, but usually these are human-made errors which can be easily avoided. That is what this lecture is going to be taking place. This is a study done in Nigeria in 2017. They have done in about 255 patients in a 1-year retrospective study where they found the major artifacts was happening on a fold artifacts and the minor one was 1% of heat. And this was done by the Department of Human Anatomy and Biology. And also a study from Spain have found that it's basically, they've taken the study from the general practitioner and about the oral surgeons, of which they also found that the major problem happens in the 39% of artifacts. So how can we, and this is an Indian study being done here in Iran, it was done in Iran. So here they have found that 92% were associated with the technical performance. So the technicians come in our lab thing, and we, the oral pathologists, should take little pain in sitting with the technicians and tell them and call them also for the during the procedure about what is happening wrong. So with this brief introduction, let me go how it goes up. What we have done is, and what you have found majority of the artifacts happening is, the major problem here is the folding artifacts are very common here. Interestingly, these folding artifacts also resemble to that of very favorite of masala dosa, which has been served by both by the Indians, North Indians and South Indians. The typical way the tissue will also resemble have a folding here, which can be easily avoided. The minimum artifact seen is by the heat artifact. So what is the problem of artifact? Anyway, we are not bothered about artifact because we are mainly bothered about diagnosis. The tissue is given to us, it's 3 days, 4 days. We get a call from the surgeon, so we've been urgent to give a report. But at times, these artifacts can also confuse with a normal structure or a pathological change. It will compromise in an accurate diagnosis because it can alter the normal morphological and cytological structure and hiding the basic features. So what are the various artifacts? As I said, the artifacts can be starting from the pre-fixation and during fixation and during the surgical procedures and in lab and even sterile storage. So these artifacts are starting from the immediately from the mouth when the tissue is biopsy is taken. These artifacts, there are chances of going up. So I'm going to take in another 40 minutes. I'm going to briefly show lots of artifacts happening with the various examples taken our department and also from few internet pictures, so that for the better understanding of for the viewers, because this is done to mainly to focus that the artifacts to be avoid artifacts in your day-to-day practice. Number one, let's start with the cytology. Cytology is a big problem because the cytologies are done by basically by oral medicines and surgeons and the private practitioners. At times, these surgeons or the clinical practitioners, they think that the slide might give a pain and they take a very superficial smear, that is, they don't give enough smear pressure on the smear. So what we see is we see an improper structures on the slide and very difficult to give a diagnosis. Few enthusiastic clinicians, they really give pressure and they keep on adding and adding it. And finally, what we get is a very thick smear. The diagnosis is a very big problem. So how to avoid it? Talk with your clinicians and maybe give a demonstration and tell them in the slide what is difficult happening up, which we do in our college, in our oral medicine department and surgery. Okay, here always the problem starts with the surgical artifacts. It's very difficult to tell them to their side also, the problem lies on you, but it's our duty to do that. So what are the surgical artifacts we're going to see here? The surgical artifacts might start from the pre-fixation also. The surgeons, when they do a biopsy, they normally try to put it immediately to formalin. Okay, before going to that, I just want to show this article which was done in Spain. They have done they have found the artifacts happening in the incisional biopsy general dental practice. They have done a very serious pathological audit. They have done lots of, I think, more than 450 biopsies were taken back, or they have done about 177 samples from the surgeons and 177 from the general practitioners to rule out what are the surgical artifacts they found, of which they found that the majority artifact from the surgical aspect was crushed because of holding the tissues and trying to take with pressure, of which dental dentists had 27% and surgeons had 10%, and the least one was a fragmentation. That was a quite interesting article there. Let's go to the artifacts happening in the surgical side or in the clinical side and how to avoid it. Injection artifact is another very commonly seen artifact in our day-to-day practice, and this can be constituted with a vesiculobullous lesion because the infiltration at the biopsy site can cause this problem because it causes bleeding with extravasation and separation of contact tissue with evacuation. So at times, it can be confused with a vesiculobullous lesion. To avoid this, it always please recommend the surgeons to give a block because to avoid the infiltration. And starch artifact is another common problem especially during the cytology because of the glove powder. So the starch powder can be a problem, and it appears as the numerous blue small spherical vacuoles, which can be confused for any pathological condition. And we also have the squeeze artifact because the surgeons normally tend to hold the tissue with a forceps. And this will include crush, hemorrhage, and splits. And also, the epithelium might be distorted in many cases. So here, the cellular details and nuclei are played darkly stained and distorted. And this can be avoided by placing a suture within the mucosa. And this is another common problem because nowadays everybody have started using lasers and electrosurgical because there's a procedure called painless procedure. So normally in clinic they give a spray and they try to take a small incision, which is really highly recommended and comfortable for the patient. But because of excessive heat, there can be a zone of thermal necrosis, tissue distortion, and the epithelial cells appear attached from the connective tissue, or the epithelial cells can come into the connective tissue, taking an appearance of microcyst. Improper suture removal also can be considered as a foreign body, and it can be histologically found in some sections. Punch biopsy artifacts are also common, which is a study done by Alonso et al. In 2008, and he had said, and because of this punch biopsy, 16% have crush and pseudocysts, that is because of excessive heat. It's very common here. So how do we avoid it? It's very simple. All you have to say is talk with your surgeons or your clinicians, tell them to handle the specimen very gently because these specimens are not taken care by the clinician, and do not give unnecessary force. Just give a very subtle force and do it very softly. That's a problem of saying the problem with the surgeons because we always try to show our fingers when it comes to wrong. But we always have to think that there are 4 fingers pointing at back of us. So it's a right time where we have to gently talk to us and go back and do a proper audit in our department and find what problem is going on around us so that we can correct ourselves. Number 1, the problem starts with the fixation. So usually any fixative is normally we recommend is 10% formalin. But at times the practitioners, they do not have formalin in the clinic, they have a problem. They try to put in some solution and give it to us. And if not properly checked, these formalin, if it's not fixed in formalin, it can give to loss of enzymes, mitochondrial damage, and RNA and protein dehydration, and you have decrease in mitosis because of anoxia. And not only that, even the nuclear changes takes place starting from the fragmentation, pyknosis, and karyolysis. And this is a very common problem we come to know, but it's reduced to some extent nowadays because they might try to put the solution in an LA bottle with saline or in a plain LA, saying that it is somewhat equal to fixative. But this is what happened when they give it in saline or in LA. It has a complete separation of epithelium from the connective tissue, resembling to that of pemphigus. So the biopsy report will completely change because of these prefixation problems. And the heme from the RBCs, that is the RBCs can also segregate the blood, and these bloods can combine with the formalin, giving to a brown, black, amorphous microcrystalline granules in the tissue section. How to avoid this? Best thing is after surgery, it is better to keep the tissue on a blotting paper so that it can absorb the blood, and these formalin pigments can be avoided. And even if you can use of picric acid can also help in the removing the formalin fragments. And the mercury chloride, which is contained in the fixative, there are chances of giving this dark brown granular deposits. Now, this osmolarity of fixative solution is very, very important because either more or less can give a tissue damage. So it is said that normally your osmolarity of the fixative tissue should be kept in a proper way. Either more number of salts or less number of salts can cause the distortion of things. On the left, you see a tissue with the hypertonic, which is completely changed, and architecture is completely changed. And this happens very problem because of the quenching techniques. Because when you try to put in a inappropriate slow freezing, so what happens is on the left you get this ice crystal artifact, which is almost similar to the cholesterol collapse and radicular cyst. So this can cause a lot of problem in your day-to-day diagnosis because it just improper like keeping rapid. It's for example, the ice which is not properly freezed or which is not kept properly can give all this problem. And you also have the steaming artifact because of false localization with glycogen and enzymes here. Freezing artifacts is a very common thing also, because it looks like a twisty holes in the epithelium. Microwave fixations are being done in few laboratories. And here the optimal temperature recommended is 45 degree to 55 degree. And underheating can reduce poor quality. And whereas overheating causes vacuolation overstained by cytoplasm and pyknotic nuclei. So how do we go for it? It's always better to recommend to keep the 10% neutralite buffer solution for 24 hours and do not proceed any processing before 24 hours and always use fresh disposable blade for any new specimen. Okay, now the tissue is being received and everything is checked. Formalin is fine. Your solutions, everything is fine. Your pH check, everything is fine. So we cannot say that problem doesn't have. The problem starts with crossing here also. At times, the surgeons or the clinicians will be very stingy and be giving a very small specimen, which is very, very difficult and it is not probable. So we have problem in handling these tissues with a small or a very large specimens. It is recommended to have specimens as much as moderate size so that for the processing shall be easier. Curling of the tissues is very common during the crossing because of the tissues are get fold. So the technician should take some time to do the proper rolling of the tissues to avoid the curling effect. So on the left is one example of the thing, and on the right side is a tissue taken from my department yesterday, which was intentionally made to show for this presentation. Excuse me. And inking is also a problem because during grossing, for the surgical margin, we try to put the inking, which is really gives a problem in the reporting the section, and which can also give the false negative margins and false positive margins. And please also request the surgeons to avoid the solutions that could be done in or some any povidone iodine solutions before taking biopsy. So that's a remedy for grossing defect. And once grossing is done, now goes the tissue processing. This is the major portions where the defects happen. Because once we gross and given to the technicians, we walk out of the lab. We completely walk out of the lab, giving the full process to the technicians. And finally, we see them only on the slide at our laboratory. So what happens here? Improper dehydration, that is too long treatment in alcohol, in high concentration of alcohol, can cause high degree of shrinkage of tissue, referred as shrinkage artifacts. When this occurs, how do I go about it? When this occurs, rehydrate the tissue section and repeat the processing. Number two, improper cleaning in xylene. Improper cleaning in xylene or prolonged treatment in xylene can also cause problem. On the left, you see the section of prolonged treatment in xylene, which made the tissue brittle, leading to crumbling and crystallization during the cutting. And if the pollution is not cleared with the xylene, that is a pic done in our laboratory yesterday intentionally for this study here, for the presentation here. We had found that the specimen was made to be not cleared by xylene properly. And what has happened is the paraffin was not taken out completely, which led to the distortion of tissue during the section. Improper embedding, it happens when you expose the specimen too long during the embedding procedures, causes excessive hardening, so it becomes friable and sectioning can lead to cracks. This is the biggest problem, the orientation problem, because we have seen our teachers and HODs saying that reorient, because at times only the tissue is on, all you see is, yes, we see the epithelium or we see only the kind of tissue. So the very common terminology used by any pathology in oral pathology or even general pathology is reorient the tissue. Why is that? Because the improper positioning of the epithelium. Here, for orientation, It must be positioned so that everything comes in one order. So the orientation is very important, and technicians and the students should have a look into it. You can always say that nothing wrong in that, what big deal, they can go for ear orientation. Please remember, when a tissue is taken from a patient mouth, either it be a polyp or the fibroma or even from SCC, for the patient, that next 4 days is going to be a hell for them. They would be waiting every day for the report to come out. So as a pathologist, we should not make mistakes in the laboratory so that the reporting time can be a little earlier. On the left, you see that orientation artifact where we see the only the connective tissue present, and after reorientation, which is evident and make the diagnosis completely normal here. So the problem or the remedy for the tissue process is very simple. Proper dehydration and cleaning is very remember, and perfect embedding and orientation is only the two remedies required for the tissue processing. Then it comes to the microtome, the artifacts related to the microtome. Usually the problem was little higher because when they were using the knives. Now after coming the disposable knives here, now it started coming down. These were the nick and blemish when you have when your knives, which we used to have like a barber shop. When we were doing our postgraduate, we had this difficulty because you will have a lot of foci of calcification. And I'm very sure seniors will admit like how the younger generation are very comfortable now with the disposable blades here. And the chatters are nothing but they refer the thick and thin zones parallel to the knife edge. That's also next because of the knife here. And compression artifact is like here the blunt knife can show the complete displacement of tissue components, especially bone finding. All you have to do is sharpen the knife. If the bevel of knife is too head, you have these problems. Addition blind artifact can also be seen in many of these cases because it happens very day to day here. What happens is there's little vibrations in the paraffin block in the section. So this is what happens. So all you have to do is you have to orient the tissue in parallel to the blade here. Moth-eaten effect are the holes from the roughening here. It occurs because of excessive trimming of paraffin blocks with greater thickness. These appear as void spaces or holes in subsequent thin sections with a long axis parallel to the knife edge. And this is another problem here. You have either one part will be thick and one part will be thin. These are all initial stages of the technician, and this can be avoided once they're properly trained here. And this is because when the wax is too soft for the tissue and when the mechanism of microtome is faulty, all these things happen. So the positioning is very important. All we need is a well-sharpened blade of microtome, and also we should have a well-trained technician for cutting. Now it comes to the water bath. We think that everything is done. No, the artifacts can also happen from the water bath artifacts. What are they? We have this process called as floaters artifacts because when there are tissues or more, when the technicians don't have time, they keep continuing the specimens. Look at this case here. We see a thyroid tissue which is not completely relevant, and this picture was taken from net. It's not completely relevant. So in our profession, in oral pathology, when we get a tissue, then we will start thinking of something related to metastatic carcinoma, which can make the life miserable of the patient. So it is said that the tissue, the water should be changed every time after each specimen so that to avoid this floater artifacts. So you have to clean, please give instruction to the technicians to clean the water board regularly and proper changing of water within each sample to avoid contamination. Now comes a major problem, staining artifacts. So the technician gets time to go out and she or he wants to finish off before leaving it so that hand over the specimens to the PGs so that they can take to the pathologist for thing. Here the problem takes place here. What do they take here? When the wax is not properly taken up, so you have incomplete wax area. If you have an incomplete wax still remaining there, you have unstained area. So this takes place because of wax being left here, and this can give a problem like a pink disease artifact. And because of this contaminated solutions which are not properly maintained or contaminated, these are the pictures what you get on the slide. And there are few area clinic cells where we see that we don't see that proper bluing there because of pale staining with eosin or excess staining with eosin. The proper ratio with hematoxin and eosin is a must, but because when these cases go for a projects or a publications, the patient's diagnosis will be beautiful, everything is fine, but the acceptance process will be a little difficult. So hence, that's the reason I'm putting pressure that make it a point that when it's very with that the grossing in charge staff should sit with the technician and make them properly trained. And whenever mistakes takes in your laboratory, spend time with them and tell them what is the defect. If not able to make it, sit with your seniors and see that doesn't continues because we are responsible for the diagnosis and for the patient's life. And there are problems happening with the artifacts also with hematoxin, either be a poorly stained or excessive stain, whatever it may be, the picture shows completely improper, leads to improper diagnosis. And you can also see blue-black precipitate on top of these sections because they are because of unfiltered hematoxin solutions here. The remedy is make it a point that the eosin hematoxin should be freshly prepared with a proper auditing here, like how do the housekeeping make the schedule and see that the technicians keep changing the hematoxin eosin constantly, whether it's used properly or improperly used, and proper removal of wax. If these two factors are properly being followed in our laboratory, majority of headaches will be over. Then comes the mounting artifact. It's 3:45. The technicians have to go because the bus is at 4 o'clock. The problem starts here. So they try to get air bubbles when the cover slip, under the cover slip, and the mounting medium is too thin or dry, or they dry too much and they try to put a slide. So that gives the cause of all these air bubbles. So these can be prevented by using the mounting media for adequate thickness and removal from under the slide. What I'm saying, it happens in day-to-day life and our day-to-day practice, but these can be avoided. And dry mounting artifact is that we try to completely dry before we don't want to see any wetness here. So what will happen is they will exhibit it will exhibit something like which have a lot of pigments underside inside, and these can be changed by removing the cover slip with xylene and remounting here. So neither dry or excessive mounting, and tapping of slide is very important to avoid entrap of air bubbles. When you can go back to your prosthetics where we always tap the impression trace to avoid the entrapment of air bubbles and impressions here. Bone related artifacts. When you get the bone specimens, we take the bone for cutting under the saw. And if the saw is not properly cleaned or not properly sharp, you have this bone dust getting deposited, and this could lead to enormous diagnosis of metastatic calcification. So this can be reduced by ensuring that say that saw blades and drills are sharp, preferably for decalcification. And decalcification has its process, either over decalcification or incomplete decalcification can also give problem. And see that when you put a solution for decalcification, check every day so that it can go at the correct stage for cutting. Then comes improper slide maintenance. This reporting is done. The postgraduates do not take the slides from the laboratory. It will be lying for 3-4 days. You have dust accumulation, which will go for a staining, quality diminish, and histopathological picture is lost. Yes, we can always restain, but these can be avoided. It can be avoided for proper maintenance. How do I maintain it? I'm very sure dental council make it very comfortable that has been given a pressure that we have to maintain these things. So nowadays, the preservation of slides is a very common phenomenon seen in a day-to-day life. And I just want to conclude here by saying that the first article on artifacts was published in 1978, and they had said that the high percentage of artifacts is associated with technical and human errors. And this can be done because how it can be done is we have to, the author recommends that we have to educate the people, all people during sampling process. All people means here the clinicians, the students, the staffs, and the technicians to minimize the artifacts. So it's a very important as an oral maxillofacial pathologist. Our triad is very important. We have to interact with the surgeons, have no inhibition to tell them what is the problem, because our common focus is to give a proper diagnosis so that the patient life should not be affected, and proper training of the technician, and don't feel bad in sitting with technician or make it with somebody to sit with a technician to avoid all these problems. The problems is very common in everybody's life, but these can be trained or changed the proper communication. The ability of oral pathologists in interrupting a biopsy correctly is directly proportional not only to the quality but also to the quantity of the specimen. So I would, my preference, reference were taken from our own department photographs and Google images, and these are the articles which I followed. So normally we think that it was me who did it. It was me. No, it always said that John F. Kennedy said in his life that ask what not your country can do for you. Ask what you can do it. So it is always we do everything for this. At this occasion, I would like to thank my postgraduate, Dr. Giovanita, who had prepared me this slide. I also like to thank my postgraduates here, and that's our department here. I also, like we need mentors in life, like to thank, and thank you so much for this opportunity. Thank you, Dr. Mandana, and thank you to all viewers here, and talk to my mentor, Dr. Ranganathan here. Over to you, Doc.
Yes, thank you for that wonderful description and detailed lecture. So I think I'm going to let Ranganathan sir give his experiences and comments of some things that he's gone through, and then we will take it to the audience by the time more questions come in.
Thank you, Dr. Tamal. That was a very, very comprehensive overview of what you're likely to face. And I think you're very right in emphasizing the fact that the bottom line is the patient should not be affected. That's all it all boils down to. And it's not only the quantity, it is the quality which is important. I think it was a very interesting observation that almost 96% of the abnormalities or the artifacts that we see in the slide are technical, which means you can avoid almost 96% of them, and which is under our control. Talking to the surgeons is totally another ballpark. Like you mentioned, the crush artifact, the suture artifact, putting it in saline in the local anesthetic bottle, and things like that. I mean, that of course needs a little bit of a communication. Does not normally happen in an institutional setting, but when it comes from private practitioners, that can always be a problem. And I think one way we have tried to avoid that at our center is talk back to the clinicians. I think that was a nice slide which you put with the mobile there with technician, surgeon, and the pathologist. And I know there are certain institutions, what they do is they send in newsletters, combine the problems they have when they receive the specimen. It helps in two ways, actually. You sort of tell the private practitioners what is expected of them so that they can quickly have a turnaround, give the report correctly, and the patient is managed optimally. It also serves as sort of another aspect is that you have an advertising platform when you have a newsletter. And it is surprising that most of the delays in sign-outs happen because of technical errors. And that's really surprising because we have standardized so many things. There is automation on so many things. We have fantastic microtomes, and that can be definitely avoided. Just before we go on to the questions of the audience, there's one question I'd like to place in front of you. In your opinion, which do you think is the most common cause for an artifact at your center? What is the first one in the top 10?
You're asking me, sir?
Yeah.
Yes, sir. The top 10, what I see in our practice is like it's from the technical side, either the sections will be thick or thin, number one. And number two is in many institutes, I could see that improper of bluing is that hematoxin is not properly taking place. And as a postgraduate, we always get confused in a period, like we could see a lot of cases immediately saying that it's an SCC. That's because of improper the orientation takes place.
Yeah, Yeah, that would be on my top 10 too. And I think the alternate thick and thin is because the wax is pretty soft. And, hematoxylin, once again, it depends on the type of hematoxylin you use. And, they say when the more things change, the more they remain the same. Naturally ripened hematoxylin actually works very well for a couple of different reasons. But the problem is we have to ripen it naturally. It takes almost a month to 45 days to prepare these hematoxylins. That's going to be very difficult in a center like yours, where there's a lot of specimen coming in. So that can be a problem. And so that definitely, yes, I totally agree with you. I mean, those are the two things. Dr. Mandana, would you like to give us your input on this?
Well, actually, now I haven't been doing this for quite some time, so I'm a little out of touch. But I think one of the things we had that was very common, especially while I was in the college, because after that I was doing my own thing, so I was following all the specifications required. But what I found was one of the common things that we find is that when there's a microbial contamination of any of their fluids, and then that comes into the stain, and because very often we have dental infections which are also a part of the cause of the whole lesion, then that is very difficult. So that is one of those things we
Very
really
true.
have to see, that if we have one patient who had a possible infection, after that solutions do need to be changed, even though it can be quite expensive. I do understand, but there is no other way really. I don't know if you can think of a more economical way. I could not.
Mm. Yeah,
And sir,
it's a bit, there are a few subtle things, for example, before they put the specimen, we just rinse it with normal saline, make sure all the blood is removed, because blood is a fantastic media for microorganisms. And if the surgeon takes a little bit of time to just, wash it off, solves a lot of problem. You don't get blood pigments and things like that. I mean, small things like that. And like I think what Professor Tamal brought into our attention, communicating with the surgeon as to what the problem in their clinical setting is, solves us a lot of headache actually, if they do it correctly. And just one more thing I would like to add to this very good presentation. One of the best way to prevent artifacts is to have what is called a self-auditing system in your institution. A lot of us don't do that, especially in oral pathology, because we don't get that very many specimens. And I myself, the biggest problem I face in my center is fading of the slides. And sometimes a slide which was done 10 years back is absolutely fine, and the slide which was done 1 month back, fades off. There are a lot of reasons for this: the quality of the reagent and where we access it, and a few things which are out of our control. So what we have tried to do is like pull up randomly 50 slides, and every 50th slide or 20th slide, depending upon how many slides you see every year, and have a chart with the self-auditing process. And I'm sure most of the labs do that. And that way we can find out which is the biggest problem we face in our center. And that helps a lot, going back and trying to look at it. And sometimes we'll catch small points, which may have totally missed without the auditing procedure. And I think a lot of labs have that inbuilt into their protocol. And the thing is, we all know what causes what artifact most of the times. But each center has its own unique problem, depending upon how your center works. And having an audit actually tends to pinpoint where we can save a lot of time and resources so that department works very optimally. Okay, let me stop here, and I think the audiences may have some question. I leave it to you both.
I would like to have a few points here, sir. It was quite interesting on listening to you. The major challenge what we have is like number one is the technicians are given pressure especially when holidays come. Say for example, day of tomorrow, India is shutting down. So we give pressure to the PGs, and PGs go pressure to the technician, and technician have to really rush and give the diagnosis because he or she want to go for a holiday. And surgeons give pressure on these reporting. So the things happen, small things happen, a problem here also. And I was surprised to see that none of the article or study have been so far done in India, so far to done on what you said, self-auditing, been done in Spain and Mexico and even Brazil. But no study has been done in India. They've done only the review of literature so far. I think it's a high time, like Sir said, that we should do a self-auditing on the slides and sit and talk and educate the all team with this. Over to you, madam.
Yeah.
Absolutely right, Tamil, because only for a cold does pressure change it to diamond. But anywhere else in the clinical context, pressure makes things worse. And invariably, everything gets messed up, and especially in a clinical context. But that's a very valid point, just like a long weekend we are facing now because of Deepavali. Those things you can't avoid, but that's true everywhere. The best thing to do is, if you get a specimen in the last minute, even before you process it, you foresee the problem, you talk to the surgeon and says, please hold on, unless of course it's a malignancy which you're talking about, or something else. Just please tell the patient that, this makes the turnover time may be a little bit longer. And that solves a lot of problem, actually. So the surgeon is also aware, because most of them are just regional people, clinicians. There are very few we get from outside the state. So they're very sensitive to the festivals and, holidays and long weekends. But it's a problem for the patient, So, but
Yes, sir.
You inform them well ahead. It's a hassle of the, trying to talk to them is really solved. Please go ahead.
Yes. So I was just asking, I put this running thing which said, what has been the greatest artifact challenge? Personally, for me, was I think around 10 years back when for the first time I came across remnants of those, self-absorbing or resorbing sutures. That made me go straight to Google.
Yes,
I
that
was
can
like
be a
totally
problem.
puzzled. Yes, and it was the first time I was seeing it, and we didn't have it in any of our, published articles by then. But then shortly after that, I found it and I found the details, and it was okay. So I was asking what others have found. So what have you all found? Have you had something so far that has totally puzzled you?
Yeah, the biggest problem actually is, which is very current today, is fillers. Cosmetic fillers, which are used in
Right.
lip, and you have a mucocele and you get a biopsy, you're going to see something which are very, very funky. The first thing I do is, the moment I see something which I cannot relate with normal histology, I grab my polarizer. It works sometimes. If it's a non-polarizable material, obviously it will not. History is a fantastic thing. These sort of filler materials, GTRs in bone biopsy, the guided tissue regeneration membranes, and these bone substitutes with implants. We are having a lot of issues with these. And but usually, history, and we have a fair handle of the surgeon, who senses biopsies, what his or her specialty is. If he's somebody who's an implantologist and gives me a periapical tissue, then I will say it's associated with an implant. When you have that sort of a relation with the surgeon, history, and history.
And then that is true. That is finally what happens. Yes. Yeah. What about you, Dr. Tamis? You have anything that comes to mind that stands out?
I had one case referred by a surgeon, had a very difficult diagnosis. Then I said, sir, I called the surgeon, found him. By mistake, he has sent the specimen in a local anesthesia, thinking it's a formalin. And we had also done biopsy without checking it, and we found a lot of necrosed tissue. And we have to do a rebiopsy, and we found it to be a lymphoma. So that was the biggest artifact. And from there, my journey started towards interaction with the surgeons and oral medicine people.
Just one note.
So was that, sorry. Yeah. So please. No, please.
Yeah, the one big thing we always see is the surgeon calls up over a weekend, just like what you said, Tamal, saying that I've taken this biopsy, I don't have formalin with me, shall I put it in saline and send it? The moment the surgeon has taken it, it's the best thing to do is put it in surgical spirit. Not an ideal situation, and every practice, every dental office has surgical spirit. For some reason, people think saline is a good fixative. I really don't know why. We see that very often, actually. I just tell them, you have a surgical spirit, grab it, put it in that. Not an ideal scenario, but definitely better than putting it in saline. And if they can transport it quickly, as soon as it comes to the lab, transfer it to formalin. And when I send the report, I send about a few bottles of buffered formalin to the clinician so that he or she has it.
I do
That's the only thing you can do in such a scenario.
That is true. Yeah. So, Dr. Samistra, what happened when, was there any difference of the tissue that was in LA from when we get tissues in water.
Yes, this was totally complained. The complete LA was completely necrosed. And what I see, I thought it was like something like an abscess. So it was a bit confusing. Then we had a proper detailed discussion with the physician.
Regeneration.
Then he said, "Oh, I totally forgot." Then he spoke to his technical chassis assistant, and she said, "So there's no formalin." So I remember you telling him put saline. So this is what a common mistake it happened. And without improper history, if it had been done, I would have given a thing as a periapical abscess. The diagnosis would have been totally wrong.
Yeah, the other way to tell the clinician is, if the LA is a fixative, you probably don't want to inject it into your patient. You don't inject fixatives into your patient unless you're treating trigeminal neuralgia, So maybe that is sort of, drive the point home, But it happens. It keeps happening because for some reason people think because we are injecting LA and nothing happens to the tissue, and nothing will happen when you put a specimen inside. But there you have, obviously that doesn't make sense, But there's some logic behind how they think that. But anyway, it happens and it's going to happen, and it will probably happen in the future.
Yes, sir. Yes, sir.
Yeah.
Quite. So Dr. Nasser Said from the US, he says what is common problem for him is laser artifacts and fixation artifacts are those that give him headaches. I guess the same thing, fixation. I'm not sure what would laser artifacts look like.
Yeah, the laser artifact is a big thing now. In fact, last week we had a workshop in which these folks did a biopsy. Their patient had a fibroma on both the sides bilaterally, and we don't often get it. One side they used a surgical blade, and the other side they used a laser. I see a lot of laser artifacts because it's like a magic wand. Once a clinician has a laser, everything goes under laser. But certain lesions, it's a big problem, especially if you're talking about a mucocele. Very small leukoplakias. What it basically does is it burns the tissue. What used to happen with electrocautery earlier on, we used to see, the periodontists used to use a lot. And once it coagulates, it basically coagulates the tissue. It's something like how the white of an egg becomes white, literally, when you boil it. You coagulate the protein. The same thing happens, and of course, collagen and connective tissues made up of aminoglycans, glycoproteins, they basically coagulate. You lose morphology. And in the case of the epithelium, I think Dr. Tamil had a good picture with lasers. It disrupts the morphology totally. And once you see it, it's pretty characteristic. And the good thing is diode lasers are not very penetrative. So that's okay. But if you use lasers like carbon dioxide lasers, which are pretty powerful, can cause extensive damage. So I usually tell the clinicians, if you're working for something like dysplasia, malignancy, which is very small, take a huge biopsy where the laser touches what you think is clinically normal. Otherwise, it's going to be a nightmare signing out these slides. It's not going to be easy. So in a nutshell, it coagulates the tissue and you lose morphology, especially with diode lasers. And it happens more in powerful lasers like carbon dioxide lasers or the anti-ACT lasers. Yeah.
Very interesting. So we have this one from Dr. Vanita. Curling artifacts give us a hard time in diagnosis. Asking the clinician to fix on a board, etc., is not feasible most of the times. Could you suggest a better and simpler way?
Yeah. All they can do for them, board is the surgeons cannot do that. Giving a specimen itself is a big deal for them. All they can do is they can keep it on a blotting paper to absorb the blood and those stuffs. And I think curling artifacts only our technicians have to take it up. So you won't have any word on this, sir? You want to put any idea over this point, sir? Ranga,
yes, Tamil, that's absolutely.
Sir, are you there?
Can you hear me?
Yes.
I can hear you, sir.
Can you hear me? Yeah.
Yes,
Tamil,
we can.
That's perfect. That's good. And I actually picked this up from some dermatopathologists I had an opportunity to work with. They do what are called shave biopsies. And what they basically do, they are very thin. What they do is they take a stiff blotting paper. And when you put the cut surface on, if it has the connective tissue, basically the blood forms a clot with the blotting paper. And it sort of fixes to the tissue. And when you drop it in the formalin, And like you rightly said, that's a fantastic way to prevent curling. And a lot of dermatopathologists do that, especially with shave biopsies. That's a good technique to keep in mind. It should not be a problem.
That's true. Here we have another one. Fillers create foam body reaction, giant cells, because I think mucoceles hardly does that. I try to use that, but still mucin sometimes can be confused. It's the same thing you were saying. Yes.
Yeah, but technically, what is I don't know who's Dr. Nazar? Yeah, okay, Dr. Nazar said, yeah.
Yes, Dr. Nazar, yes.
That's true. I mean, theoretically, when you have a foreign material, you get a lot of giant cells, but sometimes you don't get them. If it is there, it is useful. But a lot of times, they don't elicit a foreign body reaction. All they will do is form a scar tissue around it, because some of the new fillers are pretty biocompatible. But you're absolutely correct. You know, if there are giant cells, it's not a problem. But if there are no foreign body reaction, then it can be a big problem. Very true.
That is. I think we have more people saying that it was a great lecture than there's questions. But we have this, okay, Dr. Razor Winchester. That's an interesting name to have. So, well, you don't get the PDF of the lecture, but anyway, the recording stays on YouTube. You can watch it as many times as you want and go over and over again. So I don't think PDF is really essential. So please watch it as many times. And then let's have a look, since there are no more questions, let's have a look at, we saw some of the names of everyone who was there right in the beginning. And here are some others. Dr. Niharika is with us, Dr. Nandini, Dr. Sandhya, of course, Dr. Nasser we saw, Dr. Sunita, Dr. Maheshwaran, Dr. Madhu, and this one is for you. Good presentation, sample size and size has to be emphasized with the clinician. I guess asking the clinician for those. Yes.
Okay.
And Dr. Mohan, Dr. Krishna, and Dr. Joss is here. And he has, okay. In South Africa, we have a major problem with stains fading due to the exposure to high intense levels of daylight exposure.
Yeah, Dr. Hill, we have that in Chennai too. It can get pretty bright. Yeah, that's definitely a big problem. And especially like what Dr. Tapal said, you let's leave the slides lying outside. We want to do that.
Yes.
Thank you for that. Yeah.
Yes. I think sometimes we take it for granted that if we are indoors, the effect of the sun is not there. But in reality, I think the effect of the sun is there, whether we are indoors or outdoors.
I don't know if it's to the fact that we have become very quote-unquote eco-friendly and started using LED lights. It would be an interesting study to see if they have any effect on these, because earlier we used to have these filament bulbs. That used to be a problem. And now that they're all air conditioned and we use all these LED lights, I mean, that's, I know, they just popped into my mind that maybe something, if light is a problem, I mean, I'd like to see, somebody can do a study on whether the wavelength of the white light which we're using has an effect. That's very interesting. Yeah, thank you for that. Yeah.
Sir,
it's very interesting, sorry, because we have these lights, and if you look above the LED light, if it's close to the wall, there is always a mark.
Oh.
Like the old bulbs, there is a mark. There's a slight sort of change, especially if your walls are very light colored. You do get a change in the color of the wall. So there must be some effect. Sorry, Dr. Taviz, please go on.
I have a doubt for clarification. After Dr. Hill had said, will these, if these racks are shifted to an air-conditioned room, will this, is it a staining problem will get fading, will come to an end or something, sir? Do you have an idea on that?
Oh. I mean, you were saying the amount of time they're exposed to bright light.
Yes, because.
But I think I think his comment was that could be one of the reasons why it is fading. They could be other to do with your hematoxylin, because usually eosin does not fade. Hematoxylin fades off, for us at least, So we usually have a problem with hematoxylin. And it never happens with the naturally ripened hematoxylin, at least for a few years. But the other things, not with respect to light, all things equal, use a naturally ripened hematoxylin. Maybe that's our experience. I do not know what experience the other centers have. But it's difficult to make.
Yes.
Yeah,
Yeah,
totally
you have
agree.
the same comment. Yes, it's Dr. Hill is saying that quality of commercially prepared hematoxylin is not the same. Very true.
The batch is changed.
Yes. Yes. So let me see what else we have. Yeah, here we have Dr. Tabassum saying a very nice informative session, and Dr. Narmin Afilvi, I wonder where it's from. Thank you for the efforts. Dr. Pavitra, same. Thank you. Dr. Bharat, super and informative presentation. Dr. Leena, yes, lots of very nice.
Sir,
Oh, that's one of your students.
A student.
Oh, that's always nice to hear from them. Thank you, Lina.
Yes. Dr. Renzi, thank you for informative presentation. Dr. Gauri Shankar, nice presentation. Dr. Josh seems to have another query. Opinion regarding hematoxylin staining versus progressive hematoxylin staining, or regressive versus progressive.
Yeah, we use regressive because it's a little bit easier to do. That may be another good point. Maybe we should try progressive. That may not stain as easily. That's something we have considered in the past, but because of technical issues of reproducibility, we've had some problem with progressive staining. But that's a good point. That some centers can try that out, or if some centers trying it out, really appreciate the input on that. Yeah.
Here's a very original solution to our problem of not having fixatives. So Dr. Nasser says, I tell them to go to a liquor store and buy a small vodka bottle.
That's what Raga said, like go for a spirit bottle, all the
Spirit, yes, I guess.
Anyway, Nasser want vodka.
As long as the surgery is over, I think it can't do any harm.
Yes. Very good one, Dr. Nasser. Yes. So this was there, and okay, Dr. Shalini also saying very nice. Dr. Yamuna Devi also saying very nice.
Thank you.
Yes, Dr. Vinita, thank you for the informative session. Relevant inputs by Dr. Ranganathan. Yes, and then thank you. Thank you all for attending.
Yes,
And
absolute relevant and neglected topic.
Yes, it is actually, and not one of those. It's not one of those. Not one of those topics that has stardom in oral pathology, so it doesn't get that much of airtime. That's the main thing. Yes. So Dr. Niharika also says thank you. Dr. Yamuna Devi, some lights on artifacts and decalcification of teeth.
It goes same thing like it. Yes, sir, you want to say, sir? Please, sir.
No, please, Tamal, go ahead.
No, whatever happens in the bone only takes place if improper decalcification, not keeping in a proper time, and over decalcification also happens in the teeth. But teeth might require more time than the bone. Yes, sir. To you, sir.
I think most of the times what happens is it depends on the decalcification fluid you're going to use, whatever you use in your lab. Nitric acid is used. We have seen the least artifacts with those which take a longer time to use, especially if you use formic acid. But obviously, in a clinical context, you can't do that very often. It's okay in research. The stronger the acid and shorter the duration of time, the more the artifacts are. And if you do not wash the sections very well after your decalcification, hematoxin will not take place. That's what we were discussing a few minutes back. In regressive alteration, we use an acid to tone down the hematoxylin. So if the tissue retains any acid, obviously hematoxylin is not going to stain very well. So that's going to be a problem. One way we have worked, a couple of research projects we are undertaking for the orthodontist and the endodontist for teeth and bone. We use a commercially available decalcifying fluid, which is quick and more gentle on the tissues. It's a little bit more expensive. It has a combination of formalin and nitric acid and I think hydrochloric acid in different proportions. It works very fast, and we have seen that the artifacts are very loose with that. So the type of artifact you use, decalcifying agent you use, the time you use it, how frequently you change your acid, and how well you wash the tissue before you start your staining, I think are determining factors in reducing the artifacts and decalcification.
Very true. We had done this study, I think, or rather one of my postgraduate students at the time had done a study for the teeth. And I think she found that the best was EDTA as far as preserving the entire structure goes, and no splitting of the soft tissue from the bone. And then I think formal nitric, yes, that was another thing that she had found. It was, I actually don't remember it very well anymore, but that was the general study that was done, and the results were very good. Yeah. But the timing changes, of course. So, and then we have Dr. Pushpalata. Hi, Pushpa. Yes, thank you so much for being here. And yes, and Dr. Nasser also saying very elegant presentation. So I think on that note, we shall stop. It was fun as usual. All of us, I think, had our students, our colleagues, and friends in the audience. It's always a great fun to get across with everybody. Now, if you give me a minute, I shall share the certificates.
Oh, sure.
Oh, I have to add it. Okay. So yes, thank you so much, Dr. Chelvan. This was a very, very good presentation. And yes, please.
Hope I have satisfied Mandana, and I have not let down my mentor here. I was a little tense to present in front of him, actually. Thank you, sir. Thank you, ma'am.
Awesome presentation, Tamal. Awesome.
Thank you,
Yes,
sir.
and you don't have to call me ma'am. Okay.
Thank you, Mandana. Thank you, Mandana.
Yes, that's better. Thank you. You are most welcome. It was great to have you here with us, and it was a very, very good presentation. Thank you so much.
Thank you.
And sir, thank you so much again. And
Thank you
it's
very much.
always a pleasure to have you here. And I always take these good occasions to be able to chat with you. So it's great fun. Thank you for being there.
And happy Diwali to all present in this forum.
Yes. And thank you to all of you who have always been there, who make this possible by being there with us every week. I know it takes a lot of time and effort for you also to attend. So thank you so much. If you did like the content that happened today, please put a like so Dr. Tamiz knows that you liked it. And also, if you like the content, otherwise, support us by subscribing, sharing, commenting. That is how basically it just gets across and gets more and more, views. And that's how oral pathology keeps getting more and more views. I have one good news that now in YouTube, if you put oral pathology related content, like you go search for a salivary gland tumor or something like that, oral pathology actually comes up, and not necessarily, okay, I'm being a little bit mean maybe, but it is no longer the general pathology content. Now it's oral pathology content that comes up, which I feel very happy about. Okay, and with all due respect to our general pathology friends, of course. And this is the other thing that we have now running. Since we could not include everyone all the time, we have started this where you can submit proposals for your short videos, and we will go through and see, and 10 to 15-minute videos on about 7 of these series are possible. So it's open to everybody, because really I cannot find and include everyone who should be on the channel once a week, resources of time and even otherwise looking for people is limited. So I thought everybody should have an equal chance, and that is why we have this. You just have to go to our website. Don't look too much around the website. It's new. It was just put up for this. It is going to improve, so don't feel a little disappointed if it's not particularly grand right now. This was put up only for this at this moment. We will do it up further.
Sure.
And coming to next week, the next episode is a dentistry special. We have role of saliva in diagnostics and therapy, an overview by Dr. Krishnaraj Ganeshnaran. He was on the channel before, and this should also be very, very interesting. I do hope everybody will join. And before we go away, of course, a happy, happy Diwali to everybody. May the lights of Diwali light up your every moment and bring you much joy in everything that you do. And with that, let's see you next week. Bye bye.
Thank you. All the best. Bye.
Thank you. Bye. Bye.